First of all, in the algorithm addition, because I'm very important, I'm approaching the practical points of the recommendations. I'm going to do these many because all the professors before me have directed many points that I needed to discuss, but they have covered it all. They have left a very few points for me to cover. First, in the recommendations, I need to, according to this algorithm here of acute pallor, we need to approach it as acute pallor because we, at the presentation, we don't have an acute hemolytic crisis. We have an acute pallor because sometimes the mother is not reporting the urine to be discolored. So we need to approach it as acute pallor more. So to approach this, I need to put a station of acute bilirubin measurement and the jaundice before the Coombs station. We need to put it after the reticulocytic count and before the Coombs station, because this can exclude for me the presence of any hidden hemorrhage, especially in infants with low birth weight. They may have intracranial hemorrhage with hidden hemorrhage and presenting as pallor, but they will have a normal bilirubin. So I can here delineate from early presentation the possibility of hemorrhage, because if I wait for the blood loss to see it here, this will be a late thing. So I need, after the reticulocytic count, if it is increased, it may be hemolysis or it may be hemorrhage. But if the bilirubin is normal, I proceed to hemolytic crisis. This, I think, allows better and early detection of hemorrhage than this algorithm. It's a minor addition if you find it feasible. The second thing, for G6PD, if we are having ongoing hemolysis, and Dr. Hoda has approached this, the problem with G6PD, sometimes the patients are given the blood. In practice, they are given the blood, you have possibility of G6PD, go and come after 3 weeks. This happens a lot in practice, especially at the level of the residents and this forth. So when this happens, there is ongoing hemolysis. He will go, he will have hemoglobinuria, he will have a result inferior and further drop in the hemoglobin level. So there should be clear recommendations about what follow-up I'm going to do. Will I do daily hemoglobinuria, daily hemoglobin, okay? And will it be inpatient or outpatient? Because this not clear, if this is not clear, the patient will come after 3 days, for example, with hemoglobin 5, because this was not clear. I will need to follow him up for any ongoing hemolysis after this. If I cannot follow him up, Dr. Hoda has approached this very importantly, because some reports, I have put one report here, if there is a brisk hemolysis continuing, some transfuse at levels higher than the 7. We usually transfuse at 7 hemoglobin, while it is hemodynamically stable if only below 7. But some reports have said, there are not many, but they are present. If from 7 to 9, we can transfuse if there is evidence of severe brisk hemolysis still in this patient. And I think we can do this approach, especially if I'm not going to follow him up. He needs to leave and come after, for example, 3 weeks or some time after this. But if I can follow him up daily, okay, we need not to give this. But if we cannot follow him up daily, I think this is a very feasible, and as you have said, we have adapted guidelines. This is a very feasible and adapted guidelines, and there is a reference or two about this. The second thing, sometimes we, because of the difficulties and the increased G6PD in the reticulocytic population of the blood, the level of G6PD is normal, okay? So we need to give preventive instructions for the patient until they come for further testing. After several weeks, we need to give them preventive instructions for the possibility of having G6PD. We need not only to give this preventive instructions, we should put that we need to give it also for suspected cases, not for confirmed cases only. Second thing, do we need to add and approach technical details? Like, for example, some people have put details to diagnose or to be able of highly suspicious of G6PD. Some people have discarded white blood cells from the sample because they have reticulocytic count levels are high, equally and more even in the white blood cells. Some people have compared the activity with other enzymes, hexokinase, pyruvate kinase, or phosphogluconate, especially dehydrogenase, because if these levels are high, they are also elevated in reticulocytic count. But if them are high and at the same time the G6PD is just at the low normal or even a little bit subnormal, I would, if this discrepancy, if expected, they should all be high. But if there is a discrepancy between them, this may point that it will be probably subnormal when repeating the test on a normal population age after this. Also, a very important thing, because many clinicians overlook the examination, the simple examination of the blood film for typical features of oxidant damage. And I think like Heinz bodies or so, I think this needs to approach between the clinician and the lab person, because sometimes it needs special staining, special staining to find this. If done promptly within 2 days of the hemolysis, this may point strongly if we find these cases. This is a simple thing that we can approach. Also, we have to settle, Dr. Hoda has said about the timing at when we are going to do the G6PD testing. I have looked thoroughly in many authors. 2 timings have been suggested, one after 6 weeks and one after 2 to 3 months. We should settle when we are going to do this. I'm saying this because in many cases, G6PD could be a tricky diagnosis. It repeats, although clinical suspicion is high, but it keeps coming as normal. And you cannot answer the parents who are asking, do I remain prohibited from these foods or medicines or not? They are normal like this. It is strongly suggested, but it's not present. So the testing, we should settle on the timing. We should settle on adding any special techniques to avoid errors in diagnosis. Also, we need to approach in G6PD 3 things. We have to add mothballs containing naphthalene, because I know it's prohibited in many countries, but still in Egypt we are using it. So we need to put it in the prohibited approaches for patients or parents of having G6PD. Second things about 2 items. The vitamin K has been mentioned of the possible diagnosis. There is a controversy about this. Some people are saying that it is not causing hemolysis, and a few reports giving that it causes hemolysis. But if it is a possible diagnosis, we should outline very important thing, that vitamin K3 menadione carries a much higher risk than vitamin K1 quinaquine. So K1 quinaquine is less risky. We can use it because this is a very important drugs, especially for neonates. We cannot avoid it because of this report, especially that it carries a much less risk than vitamin K3. About the vitamin C now is being used excessively, of course wrongly, but it's used excessively in the era of COVID. So we have to know 2 things, that better not to exceed 400 milligrams for ages 1 to 3 years and 1,800 milligrams for older ages 14 to 18 years. As regards autoimmune hemolytic anemia, I find that we have to delineate between 2 things. For, as you said, we need to do flexible tailoring of the management. I think for severe cases with hemoglobin reaches 3 to 6 grams per cent, I need many reports. I found that many reports are preferring using intravenous methylprednisolone, even mega doses of 30 milligrams per kg per day for 3 days. Prefer to oral prednisolone. This is in severe cases, and then shifting it later to oral prednisolone with further reduction in the dose gradually according to the clinical and hemoglobin findings. So I would suggest that this be recommended in severe cases. The other thing Dr. Hoda has said about many key questions. The key questions, of course, they are excellent. I like them very much in this guidelines, but some of them are not answered, and some of them are answered, but I don't know where their position be in timing, as regards timing in the guidelines. When will I put them into the approach, do the testing? But this is not, we need to be clarified a little bit. Thank you very much.